A warm welcome to all my dear MOS members and the ophthalmic fraternity who have joined today. At the MOS, this is the 129th event that we are celebrating today with the Journal Club meet, and this is the 9th Journal Club meet that we have in with MOS, and the second in association with the Bombay Ophthalmic Association. Today we have a very interesting review article from the American Journal of Ophthalmology. To present will be Dr. Ankita Sangle, the first year PG student from Nandati Bhai Hospital. We have the coordinator, Dr. Nidhi Patwardhan, and our evergreen Dr. Parul Deshpande. With us, we have the experts, Dr. Suhas Haldipurkar sir and Dr. Gaurav Luthra as the expert panelists. So, and with us, we have the statistical analysis, we have Dr. Sabyasachi Sen Gupta and Dr. Mahendra Sethia. So, it is going to be a very interesting discussion which is going to be there on this. So, wish you all the best, Dr. Ankita, and welcome you all for this 9th Journal Club meet. We have Dr. Rajesh Joshi, the Honorary Secretary also, who has joined. And I think Dr. Lahane sir, we have requested Dr. Ragini, Professor Ragini as the Chairman Scientific Committee of the MOS and the President of the VOA. We have requested her to join. She is going to join shortly. She was down with COVID. And Dr. Sumit Lahane and Dr. Swapnesh Sawan, we are the part of the panelists. So over to you, Vaishal. All the best and welcome you all.
Thank you so much, sir. And at the outset, I really thank Dr. Suhas Haldipurkar sir and Dr. Gaurav Luthra for accepting the invitation. As cataract surgery has become a refractive surgery, and today optical biometry is the way to go. And today ELP is going to play a major role in prediction of the outcome. And today we have none other than the veteran speakers today who would share their experience today. And it would be really a very enlightening talk and discussion. So I lay the Journal Club meeting open. I invite Dr. Ankita Sangle to open and present the article. Welcome, Dr. Lahane, sir.
Yeah, welcome, Dr. Lahane, sir.
Hello, sir.
Good evening, everybody, and
very good evening. Very good evening.
Goes to both of you. Please go ahead.
Yes.
Welcome everybody, and go ahead.
Yeah, before I miss out, we have the evergreen Dr. Vaishal Kenya, whose efforts we are having and it's bearing fruits. As I rightly said, Vaishal is taking all the efforts to get everybody together and have a wonderful session. Yes,
Basically,
yeah, Parul.
Jignesh.
Bola, sir.
Who is evergreen, Jignesh or Vaishal, that we'll have to decide. But somebody
Sure.
I think before we really go on to the article, I would like Dr. Nidhi, who is my co-coordinator, to just give a brief introduction about the topic. So Nidhi, can you take over?
Yeah. Thank you. Thank you, Parul. So as Dr. Kenya mentioned that after every cataract surgery, we desire a perfect refractive outcome. And there are lots of features like a perfect keratometry, optical biometry, the newer generation IL formula, which have helped in this. But there is also one other factor which has been coming up recently, that is the post-op ELP, the effective lens position, and the factor of the post-op IOL shift. There have been some studies which have reported the relationship between the post-op IOL shift and the post-op refraction. One of the studies published in 2006, it was a randomized controlled trial. It showed that the post-op IOL shift can induce the post-op refractive changes. So there was a possibility that the stability of IOL can be an important factor in improving the accuracy of the post-op refraction. Then there was another study in 2018 which found out that the shape of the haptic, it had a major influence on the stability of the IOL. One of the methods of IOL placement which is most commonly used is the in the bag procedure. So theoretically speaking, if we want to have a more stable IOL, one of the factors that we could consider is the placement of the IOL on the anterior capsule. And this is known as the anterior capsular fixated IOL. One of the most common IOL brand which is used in this is the Femtis IOL. So this study talks about how this Femtis IOL is different in terms of the post-operative effective lens position and the effect of this factor on the post-operative refraction. So I now request Ankita to please start her presentation.
Thank you, ma'am. Good evening, everyone. I'll just share my slides. Okay. I thank Bombay Ophthalmic Association and Maharashtra Ophthalmic Society for giving me this opportunity. And thank you to Dr. Parul ma'am and Dr. Nidhi ma'am for giving me this opportunity. So the topic of discussion today is the determining and comparing the effective lens position and refractive outcome of a novel Rhexis-Fixated lens to establish lens design. This was studied by Mehdi Shazari and others. It was published in American Journal of Ophthalmology in 2020. Intraocular lens power calculation and refractive outcome prediction evolved through the years, leading to a development of newer generation IL formulas. Olsen suggested that the main source of error for any of these formulas is the prediction of the post-operative effective lens position measured as the post-operative anterior chamber depth. Another influential factor for IOL calculation is the difference in the lens design. Montero et al. Compared the pre and post-operative ACD and concluded that the plate haptic IOL showed anterior movement and the C-loop haptic IOL showed backward movement compared to the pre-operative ACD, suggesting a significant effect of lens design on the effective lens position and IOL power calculation. A new Rhexis-Fixated lens introduced is placed into the capsular opening. The design improves rotation stability and ensures a superior centration due to the fixation into capsular rhexis. Technically, fixation should lead to an ELP closer to the cornea as the lens is fixated at the anterior pole of the lens capsule. So here the three lenses are being compared: Femtis, which is a Rhexis-Fixated IOL, CT Aspina 409M, which is a plate haptic IOL, and SA6080, which is a C-loop haptic IOL. This is a video showing how the Rhexis-Fixated IOL is inserted. It is a hydrophilic acrylic lens, antero-posterior aspheric and biconvex optics. The diameter of the lens is 5.7 mm and the length is 10.5 mm, and no haptic angulation is given. So the lens is introduced through 2.2 mm incision, and viscoaspiration is done. Again, the anterior chamber is refilled with visco to protect the endothelium. There are extra 4 haptics which are hooked and tucked over the anterior capsular margin. This adds about 40 seconds to the operative time. And once all the haptics are hooked, you can rotate the lens so that toric fixation is also possible with this lens. So the aim of the study was to evaluate the differences in effective lens position and refractive outcome based on different intraocular lens designs as plate haptic, C-loop haptic, and Rhexis-Fixated lenses. The study design was retrospective, controlled, multi-center, and comparative case series. This study setting was at 3 different centers in Germany itself. The sample size was 70 eyes of 56 patients. Inclusion criteria as given was patients with intraocular lens as CT Aspina 409M or SA6080 or Femtis lens. The exclusion criteria was given as patient with intraocular lens constant optimization exceeding population average by more than 2 standard deviations. So out of 70 eyes, 22 eyes had plate haptic, 27 eyes had C-loop haptic, and 21 eyes had Rhexis-Fixated haptics. Ocular measurements were performed pre-operatively and 3 months after surgery with intraocular lens IOL Master 700, Zeiss, Germany. In 2015, Hofer and Associates published an advisory protocol for studies of intraocular lens formula accuracy to improve the validity of such studies, which was followed by this. IOL calculation was performed using 9 different formulas. 5 of them were calculated, SRKT, T2, Hofer Q, Holiday 1, and Higgins. For the other 4 formulas, online calculators were used. For Holiday 2, Barrett's Universal 2, Hill RBF, and Olsen formula. So the parameters used by these formulas, SRKT, T2, Hofer Q, Holiday 1, Olsen, they use axial length and keratometry values for their IOL calculation. Anterior chamber depth is used by Hill RBF, Higgins, Barrett's Universal 2, and Holiday 2. In addition to this, Barrett's Universal 2 uses wide-to-wide distance and lens thickness, and Holiday 2 uses age and preoperative refraction for its IOL calculations. Intraocular lens optimization was done. The lens constant, which would predict the refractive outcome measured post-operatively using the IOL power, was calculated for each patient, formula, and lens design. The lens constant, which would result in mean refractive prediction error as close as to 0 as possible, was calculated. Triple optimization was done for Higgins formula. Then ACD adjustment was done to calculate the effect of ELB on IOL calculations. Lens position of the plate haptic and C-loop haptic showed no significant difference. They were collectively evaluated as one group in comparison to the Rhexis-Fixated IOL. Evaluation of the refractive prediction and absolute error. The refractive prediction error was defined as the difference between the post-operative measured spherical equivalent and predicted spherical equivalent given by the formulas. Mean absolute error, standard deviation, maximum absolute error, and median absolute error was formed for each formula. Percentages of eyes within prediction error of plus minus 0.25, 0.5, 1, and 2 standard deviation were calculated. Statistical analysis was conducted using SPSS statistics. Independent t-test and a dependent t-test was performed. P-value below 0.05 was considered significant. This table shows study population characteristics in which more number of female patients were included. Both the eyes of the patients were included. Then mean age, IOL power, axial length, and anterior chamber depth, keratometry, wide-to-wide distance, and ACD by AL ratio was calculated. The result shows the mean IOL power implanted for plate haptic was 21.07 diopters, C-loop haptic was 22.56 diopters, and Rhexis-Fixated was 20.71 diopters. The average ELP given as the average post-operative anterior chamber depth in plate haptic was 4.51 plus minus 0.26 mm. In C-loop haptic, it was 4.41 plus minus 0.42 mm, and Rhexis-Fixated showed least 4.29 plus minus 0.24 mm. The average ACD gain between preoperative and postoperative measurements in plate haptic 1.45 plus minus 0.1 mm. In C-loop haptic, it was 1.39 plus minus 0.1 mm, and the least again in Rhexis-Fixated 1.18 plus minus 0.09 mm. Effective lens position relative to the axial length is estimated with the quotient ACD by AL. Plate haptic showed 0.194 plus minus 0.01. C-loop haptic showed 0.193 plus minus 0.016, and the Rhexis-Fixated showed least 0.186 plus minus 0.001. So p-values for ELP given as the post-operative ACD showed significant differences between the plate haptic and Rhexis-Fixated IOL, where p was equal to 0.013. ACD by AL quotient was p equal to 0.001. Comparison of ELP between the C-loop haptic and the Rhexis-Fixated IOL with p less than 0.01 for both post-operative ACD and ACD by AL showed same results, and comparison between plate and C-loop haptic showed no significant differences, where p was more than 0.05. Then this table shows mean differences in intraocular lens power and predicted refraction between IOL calculations with adjusted and unadjusted anterior chamber depth and their p-values. The p-values with dependent t-test was significant, showed significant difference in predicted refraction between the IOL calculations, where p was less than 0.000. Significant differences in predicted IOL power was seen due to ACD adjustment, where p was less than 0.05, except for one case in Holiday 2, in combination with Rhexis-Fixated IOL, where p equals to 0.082. Then for two variable formulas, the effect in refraction was a hyperopic shift of plus 0.245 diopters for plate and C-loop haptic. For Rhexis-Fixated IOL, it was a hyperopic shift for approximately minus 0.248 diopters, and the newer formula showed smaller effects in refraction. Discussions by the author was the effect of different lens designs on the ELP and its impact on IOL calculation was studied for the first time. The Rhexis-Fixated IOL showed shorter post-operative ELP measurements. Standard deviation for the ACD by AL quotient was lowest with the Rhexis-Fixated IOL. ELP is more stable in Rhexis-Fixated IOL than for plate or C-loop haptic IOLs. Due to more stable ELP, the prediction of refractive outcome seems to deviate less with Rhexis-Fixated lenses. SRK-T, T2, Hoffer-Q, and Holiday 1 showed greatest effect of ELP adjustment on the refractive outcome. The newer formulas showed smaller effects of ELP adjustment on the refractive outcome, and the Barrett Universal 2, Holiday 2, and Hill RBF showed were less affected by changes in ELP due to the lens design. Limitations by the author: small sample size was taken. Adjusted preoperative ACD was used instead of predicted ELP. So this led to the effect of axial length and keratometry was no longer included, and the effect of IOL power, IOL thickness, and shape factor on the ELP was not studied. They concluded as differences in lens designs have a significant effect on ELP and on prediction of post-operative refraction. This effect is greater on the older two variable formulas compared to the newer formulas. So my understanding in their criteria, the inclusion and exclusion criteria were not properly defined. The method of standardization of surgery was not done. It was a multi-surgeon, multi-center study. Then secondary outcome is not defined correctly, and also the clinical outcome is not shown. The sample size was small, so it cannot be taken as a reference for further studies. So the method of ACD adjustment is not explained. Number of eyes included for IOL optimization is not mentioned. And optimized lens constant, they differ from the published ones. The statistical analysis, it was a retrospective study. Separate comparison was not done for each IOL. And compounding of data was seen due to use of bilateral eyes in some cases. The results, the lens movement of plate haptic IOL and C-loop haptic IOL was opposite to the previously conducted studies. Lens stability was better because of the additional haptics, and the newer generation formulas estimate ELP better. So future scope for we have is use of intraoperative ACD measurements in combination with the Rhexis-Fixated IOL can be evaluated. Effect of shape of capsulorhexis for ELP for various lens designs can be studied. Comparison between the Rhexis-Fixated and the bag in the lens IOL can be studied. Different capsulorhexis fixation IOLs with different materials and designs should be investigated. So why anterior capsulotomy fixated lenses? According to certain studies, it says that there are less refractive surprises. There's no IOL tilt, rotation or decentration of the lens. Posterior capsular opacification is less and dysphotopsia is also reduced. So this is another type of Rhexis-Fixated lens, which is bag in the lens. It has two haptics, anterior and a posterior. An additional posterior capsulorhexis is required for this lens so that both the margins of the rhexis are tucked in between the two haptics. This is most commonly used in pediatric cases. Other is the 90F IOL. It is a C-loop haptic which has extra flanges again for tucking over the anterior capsular rhexis margin. And for inserting this, you need a different injector, and tucking over of this lens is difficult, so not very commonly used. Anti-dysphotoptic IOL, it has a groove in between the haptics. It is again a C-loop haptic, which helps in which can be anchored in the anterior capsular rhexis margins, and it was designed to reduce the dysphotopsia. Another one is the swivel haptic. This is the Indian one, anterior capsule fixated intraocular lens. It has two extra haptics made up of PMMA, and these they swivel over a pivot. So after injecting inside, the two haptics are tucked over the anterior capsular margin. So after seeing all these lenses, are we looking at the new era of intraocular lenses? Thank you.
Very nice presentation, Ankita.
Really
Thank
nice.
you.
Very nice.
Very nice.
Thank you, sir.
Yeah, over to Parul and Nidhi.
Ankita, just stop sharing your
Yes, sir.
slides,
Nidhi, are
please.
you there? Yeah.
Yeah, yes.
Yeah.
Yeah. Thank you, Ankita.
Thank you.
First, I would like to ask the panelists, starting with Dr. Suhas Haldipurkar sir, what are his comments on the article?
Hi, thank you. In the first place, this article brings to the fore what has been a fact that has been established, but we didn't really take it very seriously. The thing is, we always were wondering as to why we have these refractive surprises immediate post-op. And this lens, when it is used, it has firmly established that the estimated post-op ELP very much depends on the design of the lens, and especially when you fix the lens into the rhexis margin, it obviously has a minimum measured ELP as compared to other lenses, and it also has brought it out very nicely that depending on whether it's plate haptic or the C-loop, the position of the lens in the back is kind of decided, and there's always a possibility for the lens to shift back and forth, so which has a very strong effect on the predicted refractive outcome. That was first thing that really comes to mind, which can have a lot of other bearings in the way we'll go forward. But for the time being, this is the first impression I have. Let's see what others have to say.
Sir. Thank you, sir. I now request Dr. Gaurav Luthra to give his comments on the topic.
Yes, thanks. I think it was very nicely presented and a very nice article. I mean, this thing for presentation, because it brings forth some things which are very important. So I think what this thing highlights is that the importance of ELP, which we all keep talking about all the time, but I think this kind of elucidates on how it can be so different between a back fixation, between the two kinds of back fixations, and with the Rhexis fixation. So it kind of proves very nicely the importance of ELP, which we have always spoken about. Also, I think it also brings forth the importance of the new generation formulas, because if we continue to use formulas which are two variable formulas which take basically the axial length and the keratometries, then we are missing out on, in chances of refractive surprises obviously going to be much more, because we are not factoring in the lens thickness and the ELP and the AC depth. So I think that makes it even more clear that the two formulas which really stood out are those which take into account, in one way or another, either by artificial intelligence or by, using Barrett's proprietary nomograms. They are factoring in the AC depth, and the ELP is taken into account. So obviously the refractive surprises are going to be much less. Now, the third thing which I think the article tries to prove is that the ELP is likely to be more predictable when you fixate it to the Rhexis rather than to inside the bag, where there is more chance for the lens to be sitting in a position which you cannot determine really, and you cannot predict. So I think a lot of important facts brought out. So the choice of formulas, the placement of the lens. Now it remains to be seen, I think, besides all the things which were shown, which were highlighted in the article about the shortcomings, I would say long-term stability of the lens, whether it remains where it is fixated on the Rhexis edge. Is there a chance for this lens to kind of, with capsular fibrosis, actually not remain where you implanted it, whether there will be an IOL tilt in the future? PCO rates, it claims that, even to Sri Ganesh, I've spoken about this often. He says that the PCO rates are going to be much less. I do feel that, when you're fixating it to the Rhexis, you are leaving behind a much more, all our conventional wisdom about the less PCO with square edge and IOLs which are more tacky and sticking to the PC. Here, none of that is achieved. So the logic uses that the capsule will kind of adhere to the IOL from the back and stick to it somehow, and minimize the chance of PCO, which I'm not kind of totally agreeable to. So these are the key things which come out immediately. There are lots of other things which come to mind, but I'll allow others to comment on that.
Saurav, you are also there. So have you used these kind of lenses in pediatric cases? Probably you do a lot of pediatric cataract surgery. So have you had any experience of these lenses or any comments?
This capsule fixated IOL FEMTIS is not yet available in India, so I don't have experience of it. Few of my colleagues have been with Dr. Tassignon, who uses this bag in the lens. In fact, she uses that for all her cases. And according to her, it gives highly predictable results and very effective centered lens in pediatric eyes. So I don't have any personal experience as such for these kind of lenses.
As a corollary, I just wanted to ask, if we anterior capture the optic and stabilize the ELP, then it serves the same purpose of fixating and stabilizing the ELP. So what are your comments, Haldipurkar sir?
So Vaishal, you're talking about the in-the-bag IOLs, right?
Yeah, in the bag IOLs, but anterior capture of the optic.
Okay.
See, Vaishal, when it comes to let's talk about this lens. This is a hydrophilic, acrylic lens, and you have to get it right in the center. And we know that with hydrophilic, your capsular reaction is going to be excessive as compared to hydrophobic. And if the capsular Rhexis phimosis occurs, and sometimes it can shift the lens on this side or that side. But before that, to get a perfect central Rhexis, I think you'll have to resort to a femto Rhexis, because that's the only machine that's available today to give you a perfect central one. After that, like you said, yes, this lens does give you quite a stable as compared to other lenses. And in fact, they have done other studies in which this lens, along with double C and single C loop lenses, was tried, in which they found that over a period of week and a month, this lens continued to remain pretty stable, whereas the other two lenses did show a IOL shift. Now that IOL shift is probably the reason why many of our patients post-op, immediate post-op, they have good vision. After a week, the refraction changes. So this point is very important in a sense. When you're going for the second eye surgery, should we be waiting for a week? Now that really brings into question the bilateral simultaneous cataract surgery where, if the IOL truly is going to shift, is it not worth not operating immediately and wait for a week so that you have a chance to, reset the power for the other eye?
Very true, sir. Very true.
One thing with this is that though this IL shift, what we do is we do the A constant optimization for these IOLs. So we are taking into account the average shift which occurs in all these lenses. Like in this study, as rightly mentioned, and that's what we see, that if the patient has immediate hyperopia, little bit, it kind of shifts to emetropia in the postoperative 1 week to 3 weeks period, which we observe. While in case of FEMTIS, it's the other way around, where it's a myopia which shifts. So I think when we are thinking of IOL shift, except of course there will be refractive surprises which might be because of the entire back complex reacting differently to the IOL. But I think average IOL shift we have already considered when we optimize the A constant for any IOL. That's why we find very less number of refractive surprises, even if every IOL shifts little bit in the post-operative period.
Oh, Dr. Sengupta, are you there around?
Before that, can I ask Dr. Gaurav to comment? Yeah. Dr. Gaurav, you could comment, please.
Okay. Yeah. So I think what you spoke about, Vaishal, was the optic capture. Is that what you want me to comment on? Like,
yeah.
So I
optic
think
capture and what Dr. Suhas Haldipurkar sir said.
Right. All very relevant points. What sir is saying is by experience that, all these factors will come into play. But if we are talking about anterior capture of a back fixated IOL, first of all, we would have to choose the lens because some of them come with a posterior angulation where, the lens will not be stable, whereas others come with no angulation and they might be better. Then single piece lenses are by itself, single piece hydrophobic lenses are difficult to capture as compared to like three-piece lenses, right? Because of the haptic fixation being much wider. And so stability of capture, the perfect Rhexis, as sir said, maybe a femtorhexis, the perfect size, perfect position. So lots of variables to look at. And then, of course, these square edge lenses, which are hydrophobic, if they are too far forward, although it is known that the haptics are the ones which are going to cause the irritation to the iris and cause the UGH syndrome possibly. But, you can't be sure that the big optic, which is anterior captured, what it might do. So, I mean, lots of things can be studied. And I think intraoperative AC depth measurements, as was suggested in this study, may be of some value, and maybe some microscopes which can have integrated AC depth studies might help us. So all this is hypothetical, but exciting. Yeah.
Yeah. So I think, can we move on to Dr. Sengupta?
Yeah, sure.
About the statistical this thing of the article?
Before we move on, can I add one more point from the study?
Yes. Yes.
In this study, one more important thing which I noticed was that they checked the AC by axial length ratio. And what was striking is that in the capsule fixated IOLs, it was highly predictable as compared to the non-capsule fixated IOL. So when we see the AC by axial length ratio, I think if it is more predictable, the newer formula which are based on ray tracing like Olsen or theoretical formulas, they will be far more accurate with these kind of IOLs, because you have a very highly predictable AC by axial length ratio, which is not there in other type of IOLs. So that can be one of the important clinical thing which can be taken into account when we develop newer formula. And these kind of IOLs may be more predictable with ray tracing formulae in the future.
Ray tracing formulas till date have not given what they were theoretically supposed to give, because in practice they have not been, even the phaco optics formula has not delivered what has been said. Principally, they didn't know where to take the ELP, and the anterior capsule was taken as the area for ELP.
So with the end in other IOLs that is unpredictable. Well, with this, because in this study they measured it, specifically, and it had least standard deviation with FEMTs.
Okay.
Dr. Sengupta. Dr. Sengupta?
Yeah.
Yeah.
So a couple of points, a lot of things have already been mentioned, but the first thing is that if it's a new lens, like this, it should always use a prospective design, even if not a, randomized and whatever, but at least it should have a prospective design. Now, this is a retrospective study, and we all know, there can be issues with things like that. And then all the three lenses were entirely implanted in three different centers. So one, I think the Zeiss lens was used in Munich, the Alcon lens was used in Frankfurt, and the Femtis, I think, was used somewhere in the Netherlands. So, so all surgeons operating on using the Femtis are all in one place, or maybe perhaps just one surgeon. So, looking at the video that was shown and the lens design, whether actually, especially if you don't have an absolutely round Rhexis, especially in different hands, whether there is a learning curve in others, and whether you can actually get what you want, that absolute centered lens, which is right at the effective position that we have sort of started out to do. And only time will tell when we get our hands on something like that. But then, unfortunately, there are not too many surgeons who have used this, at least based on this study. So, we'll basically have to wait and see what happens. Also, a quick statistical point is when you have 76 eyes of 56 subjects, that means then some patients had both eyes and some patients have one eye. Now that, that falls under an entirely different kind of statistical gamut, which we call repeated measures. And that's because, as you can understand, some eyes have, some patients have both eyes. What if 10 people who have both eyes are all short axial lengths? So both eyes are going to have even more influence on the overall results, isn't it? So it is always better, therefore, to have one eye from each patient. So a retrospective design and this repeated measures is definitely something, and you can do some different kind of statistics to get over this, but that has also not been done. The number of eyes are also small, so overall, from a robustness point of view, the article does not sort of, stand its test. Also, effective lens ELP is actually being equated to postoperative AC depth. I think that's what I gather from, though I don't do a lot of cataract surgeries, but I don't know whether that is the right way to go, or whether you look at the iris plane and then look at the the apex of the lens and then calculate difference between that. And what you will get it is in microns. Here we're looking at millimeters, and so if you look actually at the ELP of the haptic or of the new lens and the others, it's almost 300 microns difference. So one is 4.29 and one is like 4.51. So, it's like almost 0.3 millimeter difference. That's like 300 microns. So that's, I think overall quite a large sort of, difference when you're looking at it from the, from the effective lens position. And also, when you look at it later, because we feel that, a lot of change happens. I think that's why the haptic IOLs are not in vogue, because we feel that they are going to move, and they do. However, when you look at the results from the study, the C loop and the haptic loop, there is no difference in the effective lens position at a later date. So I don't know whether they move immediately in the early postoperative period, but then later on, it doesn't seem to be making much difference there. So, so whether there is a lot of problems which are already happening with the current lenses, and that we are getting too many refractive surprises, only then we will need something like this, isn't it? Which is slightly difficult to implant, slightly requires more manipulation, and more importantly, Haldipurkar said, sir said, we need a femto, isn't it, to make sure that the Rhexis is like that. So, the sort of the question I think that I want to ask all of you is: do you really get that many refractive surprises with using? I think most of us use the C loop IOLs. So, is there too much of refractive surprises that we are even thinking about something that is, if something is not broken, it probably doesn't make sense to break it and adopt something new. So, that's why the Tasignon lens hasn't really caught up as much as we think it should, because it is complex as a procedure, and there is not much need for it, is what I feel at present. Overall, and lastly, I think a couple of more things I wanted to sort of say is yeah, I think these were most of the things that I thought were worth discussing. You are muted, I think, Dr. Parul.
Okay. So in the initial part of the study, they have kept the C loop and the plate haptic as a separate. And when they have analyzed actually the IOL outcome and
Combined.
the refractive error, they have combined it. But
Yes.
from our experience that we see, Zeiss has a tendency to move forward as compared to the C type lenses. Now it's very conflicting. So in introduction, they said because it is anterior, Zeiss is anterior, this is posterior. And now when they are analyzing their results, they really grouped them together.
They say there is no difference, so we have grouped together.
It's,
What's the
I
point
don't
of
know,
doing the
it's
whole
not
year?
acceptable, I think. Dr. Gaurav and Dr. Suhas sir, what is your experience with these two lenses? You know, the back lenses with the plate haptic and with the C-type haptics.
See, with
Let Dr.
regards to,
Haldi
okay, okay.
Please go ahead, sir.
Yeah, with regards to the experience that we have with these different lenses, obviously a C loop is going to position much posterior than a plate haptic. That all of us know. The thing is, sometimes see, most of the lenses that we use, like for example, if you're using a Acrisoft material, which is tacky, so it has better chances of sticking to the posterior capsule. And with regards to plate haptic, what we have noticed is, like if a patient post-op, does have a bit of a myopic astigmatism, I kind of wait for that lens to kind of take time to settle back, because I expect that the plate haptic would also eventually has to settle down, or the capsule has to come and get stuck on the posterior. And but see, the studies they have done, they have clearly said the ELP that was measured post-op did show that, barring these capsule fixated lenses, the second in line was plate haptic, and finally the one with the deepest ELP was C loop. That means even the study has confirmed that the C loop does go posterior and gives you the longest ELP. Gaurav.
I think you're absolutely right, but then the C loops are usually the posterior angulated ones also, whereas the plate haptics are plain. I mean, they're planar, so they would probably not be posterior angulated, and that's why with the posterior angulation you will have less PCO. That's what was the idea of the posterior angulation, because they are kind of hugging the posterior capsule and pressing against it, using the maximizing the effect of the square edge. So you're absolutely right, sir, and so here I would like to bring in that with the Zeiss lenses, as Dr. Parul was mentioning, I remember using the one which was coming with the preloaded injector with the hydrophobic acrylic 3. I'm forgetting the name of that lens. Lucia. There were big surprises with that, and now see, that means that brings in another variable that used to have a very big overall lens with including the haptics, and that used to cause a forced kind of a posterior angulation, and then it would settle down and there would be initially hyperopic surprises, and then over a month or two these patients, and so that was a big problem. In fact, Zeiss had to kind of withdraw that lens and bring in a new design a few months later, and then these problems were solved because they decreased the total length of the lens. So it's not just that tells us that there are more factors to it than just what we can understand here when it comes to these ELPs. And also I would here bring in the fact that using trifocals now over the year, I started using them with a little bit of a doubt in my mind whether these will actually be good as far as PCOs and as far as refractive stability and refractive results are concerned. We've actually seen that's a plate haptic trifocal, the AT LISA trifocal. We've seen very good refractive outcomes and stability. So as I said, there may be more variables than what we are kind of assuming for them to be there over here. But all other points are of course valid as discussed by everybody.
So what is the role of A constant optimization also? Actually, that has a lot of role in terms of the refractive surprises that we get in these cases.
So, I mean, we read about how they have done the constant optimization here by doing post-operative AC depth measurements and then going back and back calculating, and for the theoretical formulas and the third generation formulas, where ELP was not taken into use. I mean, they've used that, and for the newer formulas where they don't allow you to use changes in ELP, they've used the other way to kind of manipulate that. So yes, I mean, this would help you in optimizing the A constant. But what's happening is that if you look at the ULIP constants and on the other side, which also gives up, that is already taking into account this optimization, which they have actually done, manually. So if we go with the optical A constants of these IOLs, which are come with the manufacturer, they will probably not be the updated ones. And if you go with the updated ones, which are coming through these 2 or 3 sites, like the ULIP site and the couple of other, in fact, even Uday Devgan's this thing, what you call the Super Ladas and these other things, they are actually constantly updating their things based on these factors themselves. The optimization of the A constant is constantly happening now. So in fact, I would think that here in this study, they've optimized the A constants by back calculating from their results, but the total number is so small that, probably doesn't, come out as a very strong point. And then of course, both eyes of some patients being operated will kind of bias it anyway. But I don't think, and as Dr. Sabyasachi said, that is there a real need? Now, there are two sides to the same story. One is that, we've come a long way in the last 10 years with optical biometry and with better K measurements, better axial length. So, I mean, we are removing all the confounding factors. We first became great at measuring axial length. Then we became great at measuring corneal measurements. Then our formulas have improved. So we've come a long way. And I still think there is a lot of scope for improvement. So, even those 3 or 4 out of 100 refractive surprises that we might get, relative refractive surprise, because the definition of a refractive surprise has changed. Now, even a 0.5 is a refractive surprise, So if we look at all the new formulas, which are giving us like 90% or 92% or 93% plus minus 0.5, I feel that today, even these are not good enough. There is scope for improvement. There's no doubt. And we can only if we have another 2 or 3% added to this, there's nothing wrong with it. So if some kind of a new IOL design or an upgrade in the formula or upgrade in our understanding is going to help it, the day we reach maybe 99 will be the day when we can probably, 99 of 100 people getting within plus minus 0.25 is probably where we might want to rest. And I still don't know whether that's correct. So I think both sides, but yes, whether that effort will be worth it, whether amount of effort that goes in, what we spend and what we kind of, there may be other issues which are more important to address than just this much. So, I mean, both sides to the story.
So the article talks about that the 4th generation formulas, the refractive surprises were less. Okay, so there the need for A constant optimization probably would be less. But there are many people who are using 3rd generation formula. So if you ask me, my practice, probably I still use SRKT formula a lot. So in that case, do we really need to do an A constant optimization? I am not sure. Dr. Haldipurkar sir or Dr. Gaurav, if you could answer, the 3rd generation formulas, do we really need to? Or we just accept whatever is coming from the company?
No, Parul, I would look at like this. Now with the 4th generation so easily available online, and I think every practice, would try and have an optical biometer, because in the article, if you look, they are talking about, like Gaurav said, even if you get, plus or minus 0.5, we accept it, but we have no reason to accept it if we go in for something new. Like in the same article, he talks about intra-op OCT measurement. There, at the end of the cataract surgery, they put an endocapsular ring, and then from anterior capsule to epithelium, that measurement, that they say intra-op, ACD along with pre-op, ACD together, you incorporate it into the formula, it would probably give you much better reading. When they say much better reading, they would probably take you to plus or minus 0.1, 0.2. So that's the direction in which they are going. So if you have to use this generation 3 formula, then obviously you'll have to do constant, a constant customization, or else your surprises are going to be plus or minus 1 instead of plus or minus half. And what happens is, when you promise a sky to your patient, and when you land up with a refractive error, it's you get defensive. It's very difficult to explain. Like, only yesterday I had a patient, very old man, but he says, doctor, I'm very, very AAA. So give me a valid reason why, after doing 5 or 6 times my IOL master reading, you still get plus half surprise. When I get plus half for it, and he comes out 50 days, and that plus half becomes plus 1. I cannot explain to him, I cannot explain it to myself. If such occasional surprises do occur. So if you have to really cut down on those surprises, from 3rd generation to 4th generation is the shortest way forward.
Okay, thank you, sir.
In fact, okay, Dr. Sen Gupta, go ahead. Then I'll
Yes,
chip in with
so
something.
very valid points that all of you are mentioning. So we need to optimize better, but however, whether a whole new IOL needs to be incorporated and, going through so much effort is sort of I think the sort of exercise for this article is the new IOL now. So, we already have the armamentarium. We probably need to do better with it in terms of optimizing and, in terms of measuring better, going to better formulas. But whether a whole new kind of IOL is justified is something that, is something that we need to think about. So, your comments on that, and we can take it now or later.
Yeah, Dr. Gaurav, please.
Yeah, I think my internet is a little unstable, so I missed part of that. But anyway, what I was trying to say was that with 3rd generation formulas, you need even much more to do the power optimization. I mean, the A constant, because your personalized A constant. See, because if you're using an optical biometer along with which a Barrett's or a Hill RBF will work well, because they won't work well with
we are not able to hear him.
Yeah, internet is unstable.
And just to answer Dr. Sen, see, well, there's not really a need to go for this lens, except that, am I here?
Ultrasound. There the need goes down.
Gaurav, you'll have to just mute Dr. Haldipurkar is just talking. I think your net is not very clear.
Who's?
I mean, yeah, not audible. Gaurav. Yes, sir. Haldipurkar, sir.
Sabbasachi, what I was trying to say is, your constant query is, do we really need this lens? No. The article has highlighted one thing. If you really want a good stability, this is the lens that gives you a stability, because that they have proved in a couple of more studies where when you compare this lens with other lenses, the post-op period for almost a month, the femtis stood very stable. As compared to that, your C loop and double C loop, they shifted. Well, the shift after a week was very gradual and less, but the shift was there all the same. But fortunately, this lens stayed. So when you have a stable ELP, that helps you predict better in your formulas. So that way it helps. Beyond that, I don't think any of us would shift to this lens, because this is one, it's a hydrophilic lens. Number two, when it is fixed into your Rhexis margin, your bag is all literally empty, and it's full scope for epithelial cells to grow, and you don't know. See, they say because the lens is stuck on the anterior capsule, capsular fibrosis may not affect it. And probably that may be true, because people have been using this femtis lens for quite some time now. It's not a new lens. Maybe at least 2-3 years in Europe they have used it. And I'm sure they have probably experienced that. But the thing is, because it's hydrophilic and because capsule can fibrose, would it shift the lens on either side? That is one thing. There are a lot of downsides to it. The only good side is we have come to know, and the awareness has increased as to, yes, different lens designs give you different locations and shifts. That is all that we learned from this study.
Yeah.
I think Gaurav can speak now with the video off, so your net will be better.
I changed my connection, so I think I'm back. Am I audible now?
Yeah, very much, sir.
Great.
Yeah,
So in fact, I was
very
just
much,
trying to
very
point out
much.
that for generation 3 formulas, your A constant optimization is even more important. So rather than for those people who may be using one of the newer generation formulas. But on the other hand, about this, what Dr. Haldipurkar sir just said, that Rhexis. So this study probably just tried to tell us that a Rhexis fixation may be the answer to move forward on better prediction and better stability of the ELP. And indirectly, it may actually help us get better results with our 3rd generation formulas, because, the ELP is less likely to be kind of variable. So, you have kind of again fixed 1 weak area of the 3rd generation formulas where ELP prediction was not being taken into account, because we are not using lens thickness and AC depth into those formulas. But here the ELP prediction is much better. So it might just kind of improve. But I think it's definitely the way forward to see how we can improve ELP stability and predictability. And it may not be this lens, which is probably the answer to this, but somewhere on we are moving forward on that line. At least we now know that Rhexis fixation is definitely going to give us better stability and predictability stability of ELP than something in the bag, which could, also move later. And so long-term, I think long-term studies with stability and, post-op AC depths done over 3 months, 1 year, 5 years to see how it changes with capsular changes and everything may also give us much more, information here.
Yeah, one point which comes to my mind is that even A constant optimization for hypermetropic eyes would be different, emetropic and myopic would be different. And with artificial intelligence coming in, you see different, they have data sets for hyperopic, emetropic and myopic. So that makes more sense than this thing. So definitely the fourth generation formulas optimization would be much better.
Sir, also I'd like to point out that other problems which might be associated with these lenses, like the damage to the anterior capsule while implanting, what is the incidence related to that? And because it is closer to the iris, so the incidence of iris chafing or long-term uveitis, that also needs to be studied.
Absolutely.
Absolutely.
So any experience, personal experience of any of the panelists with these lenses or similar lenses rather? Okay.
Although, I do a lot of optic capture, in situations, and I do notice that, it kind of locks in the lens quite well. So I'm quite convinced that, if we can fixate something to the rhexis, especially the anterior rhexis, or maybe to both the rhexis, like the bag in the lens, kind of a thing, I'm sure that would, but then we have to do bigger studies to look at the other problems associated with what we are doing. For example, problems with, as Dr. Nidhi pointed out, that maybe iris chafing there, because it might bring in other problems, which, we might be trying to solve one and, introducing new variables and new things. So they all require much more elaborate and longer studies, but it's all very exciting to see that, when you see these initial results, because it opens up new vistas, new thought processes, and maybe new designs, and a lot of new people will start thinking about how we can make it something which will, be stabilized to the rhexis and yet not have any of the, cons of a design like that. So I think it's it's always worth investigating new things, and, something can come up which will improve the way we work.
So I had just one last query. I wanted to ask, among those who use optical biometer, apart from Barrett suit, is anyone of you using any other fourth generation or other formulas?
I'm using Hill RBF regularly because I was an investigator for Hill RBF. And Hill RBF has become much better and more robust now, because it has included, it's got a much bigger range, and it also has, takes into account the 2 more variables than what it used to before. So essentially, if you looked at the finer print in this study as well, you would notice that the Hill RBF tended to perform now a little better than even the Barrett's. The kind of fine tuning of the Hill RBF seemed to be a little better. So they are neck to neck. In fact, I do both Hill RBF and Barrett's for all my patients, and they are mostly there. And when I see a difference between the two, I become very, very careful about why. So we kind of go back and recalculate. And we have seen sometimes that we actually end up going by the Hill RBF and finding a better result when there is a significant, that happens only in maybe 1 out of 10 or 15 patients. But that's all not scientifically done. So, it's not studied.
Sir, Hill RBF is currently not freely available, I guess.
It is freely available. You can just go to rbfcalculator.com, and always the updated version is there. But on the LensStar, it is integrated. But if you are not using a LensStar, then it is available online, which you can use quite freely.
I have a small experience with a Kane formula, which is available, which is again a hybrid formula, which uses the artificial intelligence, just like the Hill RBF. This Kane formula I've used basically for keratoconus patients, because they have newer generation keratoconus specially designed formula. So Kane keratoconus has given very predictable results in mild keratoconus cases.
Absolutely agree with that.
So, so I just have one more question, is that we understand that this lens is still upcoming, but do we see this lens in some of the complicated cataract scenarios? So let's say we have a PCR and we don't have an intact posterior capsule, and we have this lens in our hand. So can we still implant an in-the-bag lens, or a patient who has a pseudo exfoliation, or a patient who has any other this thing? Do you think that this lens has a better scope in those scenarios? And which conditions do you think this lens may be better, and where we can't implant it in the bag IOL?
Okay, I can just answer
Yeah.
that. Unless you plan to put this lens, it's difficult to put it as an emergency lens for the simple reason that it will work good when the Rhexis is small and central. Number two, if you have PCR and then you want to put it, and provided you have a central circular Rhexis, I think you can do it absolutely and it will work good. But if you're talking any special cases like pseudo and this and that, obviously no, because this takes support on the capsule and pseudo excavation is definitely not a case where you would use.
Right.
It does take into account the pseudo, I think this photopsia, it actually reduces. So maybe there are some.
With the masket lens.
So even this lens, I presume, the dysphotopsia is likely to be.
It will, because it's closer to the iris.
Yes. So I think.
So it was a brilliant, well-balanced and insightful talk given. And really, sir, it was a treat to hear you after a long time. And Gaurav, Dr. Gaurav, it was really very, very good talk from both of you, and the points which were discussed were brilliant. So finally we came to know that whatever comes out new, we dissected it so well that we know that we still have to use the optical biometer, the 4th generation formulas, and we can still stick on to our in the bag fixation of the lens, which is versatile and good in all situations. But in special situations, as Dr. Suhas said, this kind of femtis lens would be better. So I now ask Dr. Rajesh Joshi to give the vote of thanks.
Yeah, before that, I would just like to conclude the concluding remarks. The articulation of thoughts of both Dr. Gaurav and Dr. Suhas Haldipurkar is so good. They put the point across so nicely, and I'm sure the viewers are really going to get benefited with the thought process. And it's absolutely crystal clear. So thanks a lot for joining. And of course, Sabyasachi, as usual, is always there right on the dot. Whatever he speaks is all research oriented. So nice of you, and with statistics on. So thank you very much, and a very nice presentation by Ankita, well moderated by Dr. Rahul and Dr. Parul and Dr. Nidhi Patwardhan. Yeah, over to you, Rajesh, for the official Thanksgiving. We have a gallery view shot, Syed, before we sign off.
Yeah.
Yes, sir, sure.
Yeah. Well, welcome, Dr. Sumit.
Yeah, Sumit is also there. Yeah.
Yeah.
Yes,
and,
thank you, sir.
We had Saurabh also putting a very good, valuable inputs from his side. And as a viewer representative, welcome, Dr. Sumit.
Yeah, that was really a wonderful discussion on the entry capsule fixated IOL and effective lens position. It was possible because of initiative of President Dr. Jignesh Daswala, sir. Thank you, Dr. Suhas, Dr. Gaurav, for valuable inputs on the article. And of course, our own Dr. Sabyasachi for critically analyzing the article. Really valuable inputs and perfect example of how to read a research paper. I thank Dr. Ankita Sangle for presenting today's topic. She really presented very well. Many thanks to coordinators of today's journal club, Dr. Nidhi, Dr. Saurav, who have given really valuable inputs, Dr. Parul and Dr. Vaishal. They really worked very hard for the journal club. I'm also thankful to office bearers of BOA. Special thanks to Lahani sir for joining. Dr. Sumit, Dr. Nikhil, Dr. Zain, Dr. Sapnesh, all office bearers of BOA. I'm also thankful to all those who have joined on virtual platform, and of course, Entor for the technical support. Thank you.
Yes, yeah, let's have the gallery view. Can everybody have the videos on? A quick for our posterity records also. Syed, are you ready?
Yes, sir.
They want to put their video also?
Yeah, they're putting the videos on. Everybody, please put your video on.
Sir, are we ready, sir?
Sorry?
Yes, done, sir.
Syed? Yeah, done.
But I would like to thank
Run your video
viewers,
quickly.
It was really nice to be here with all of you, and
Yeah,
thank you so much for inviting me, actually. And thanks, Vishal, for sending me this. I actually enjoyed going through this because this is very close to my heart, and I enjoyed reading up and discussing today's. Brought a lot of new information to me as well. So thanks a lot.
Great, great. It was really a
Gaurav,
treat to hear you today.
yeah, as always, Gaurav. The way you put across the points, it really convinces the other person on the other side.
Thank you.
Very nice.
So, I think.
Thank you, everyone. It was a
Good
very.
night. Yeah.
Chala,
Bye.
thanks a lot, everybody.
Good night.
Thanks for
Thank you
joining.
so much.
Take
you,
care.
everyone.
Good night. Yeah. Sayyed? Chalo. Thank you very much. Now you should send us the head count, Sayyed, and the gallery view photo.